Good morning, and thank you for joining us today for an exceptional session on some very compelling clinical findings. My name is Marcus Calabro. I'm the Director of Sales and Marketing at IEGO. Here at IEGO, we've been dedicated to serving the dry eye community since 2003 with our innovative and patented OTC products, driving patient awareness, and supporting clinical research in this area. We are honored to have acclaimed optometrists Dr. Amy Now from Corbin Associates in Boston and Dr. Jeffrey Sonsino from Optique Eye Care in Nashville presenting today. They both spend most of their time seeing patients with significant anterior segment disease. This 50-minute session will share case reports and highlight a recent research study which shows that patients with keratoconus should be screened and treated for dry eye. Because this is a live event, I encourage you to participate by asking questions via the chat on this page, and we'll do our best to answer them. Welcome, Dr. Now and Dr. Sonsino.
Hello, everyone, and welcome to a presentation that Jeff Sonsino and I are doing about keratoconus and how these patients also have dry eye that needs to be treated. So I have a private practice in Boston, Massachusetts that has been known for dry eye disease and medical contact lenses for almost 100 years now. And I sort of took the torch over from Corb, who's been a great mentor for me. We're going to do two cases. The first case is someone that was referred to me by a colleague who works a couple miles down the road. And this was a 34-year-old Caucasian female with bilateral moderate keratoconus who was really having a hard time wearing her contact lenses more than about 4 hours a day. And so she came over and I took a look at her. She had a history of cross-linking in 2019 at Mass Eye and Ear. After the procedure, she remained contact lens dependent. And she reported also that her vision got blurrier as the day went on, and that also her eyes were very dry in the morning. Her lens history was around age 20. She was fit with corneal gas permeable lenses in both eyes. She wore them for many years until she got the cross-linking, after which she was refit with Ultra Health in both eyes, but still reported that it really wasn't any better. She was still just getting about 4 hours a day. So her referring provider decided that they were going to fit her with scleral lenses. They fit her with Aculens, mini sclerals, both eyes. They were coated with HydraPeg. She was inserting with Neutrophil, cleaning with Clear Care. She was told to use wetting drops, and she was doing that about 15 times a day. And again, she said, I can wear my lenses all day, but they're just torture after about 4 to 6 hours, but I have to keep wearing them for my job. I can't take them out. I can't see with glasses. So at this point, I look at her in the microscope and I look at the lenses, and in Boston, we have a lot of doctors who really fit lenses well. And this case was no exception. Her scleral lenses look really good and her eye looked pretty quiet. And I thought, oh man, I don't really know what I'm going to do to change this. So I took the transilluminator and I transilluminated her lower lid. And I said, yeah, I think that there's some meibomian gland atrophy there maybe. And I also did what's called a core Blackie light test. This looks for poor lid seal or nocturnal lagophthalmos, and that was positive. So I started to ask this lady a little bit more about her lifestyle. And she said, I'm on the screen all day, 12, 13, sometimes 15 hours a day. I sit down all day. She said she had a good diet. She did wear makeup 7 days a week. And she only drank a little bit of water. She did drink a fair amount of coffee, but that's a diuretic, so I don't count that. Okay, so at this point, what I did was I called in my tech and I said, Angel, let's just get a quick meibography on this patient. But before I go over the obvious, I want to just draw your attention to the lid margin, because this lady's lid margin was quiet. It is no telangiectatic vessels. It's not injected. It looks pretty good. And if you do a cursory evaluation of this, you're probably going to think that's okay. But if you look under high magnification, what you can see is that her meibomian orifices are plugged. And then there's one that's actually missing kind of over to the right a little bit. And to the left, their structure is abnormal, which probably indicates some scarring. So that's always a clue, even in cases that look a little, pretty normal. But we were surprised to see the amount of atrophy that we had. So the first thing I want to point out is that if you're going to do a lipid layer thickness, to get them in their native state, you want to have the lens off for about 24 hours. But in this case, I left it on because I wanted to see what was going on over that contact lens. Your upper lid has to pass over that big piece of plastic all day long. And so I want to know what's going on there. You can see that she's got partial blinks. You can look at the lipid thickness. It increases at all, even when there is a blink. She's got tortuosity on the upper lid. She's got some moderate atrophy up there, and the lower lids are highly atrophic, and she's got some dilation of the glands that are remaining. So at this point, I said to the patient, I shared this with her, and I said, let me just go call your doctor. I'm not sure this is the lenses. I think you might have dry eye. So when someone refers me a patient, and now I think I'm going to have to change course, I try to be courteous and let them know what's going on. So I call the doctor up, and they don't really like treating dry eye. So I said, there's this stuff going on. I like your lens fit. Do you want me to just refer back to you, or do you want me to take care of it? Just do it. I think they were kind of done with this patient because she'd done so many refits. So I arranged for her to come back. So what did I do? So I had her back. I'd already done the lip review. I'd already done the core Blackie light test. What else do I do on this patient? So I use my Boehmian gland evaluator. I'm going to do MMP9. I'm going to do osmolarity testing. I'm going to obviously do vital dye staining. I'm going to do Schirmer's strip. And then for this patient who, although she had a good diet, she was inside all the time. And for dry eye patients, we like to get a micronutrient test. So I look for B12 deficiency D, and I like to check omega-3 levels. This patient did not have a primary care doctor, but she wanted to get this stuff done. You can actually buy these tests online and get them sent to a lab. So that's what we did. I do a proparacaine challenge because this is a patient who's wearing scleral lenses and still has discomfort. So you want to make sure they don't have corneal neuropathic pain. And we do what's called a swim goggle test or an evaporative stress test, which I'll talk about in a minute. So in terms of diagnoses, can you go back, Jeff? So her diagnosis, the obvious thing is that she's got moderate to severe MGD. She's got a bad lipid layer. She sleeps with her eyes open. She's partial blinking, which is definitely true when I was watching her. She just did not close her eyes all the way. She was vitamin D deficient, but her omega-3s were normal. Her Schirmers were normal. She had pretty significant lid wiper in both eyes. Her MMP9 was just a little bit positive, not very much. Osmolarity was normal. She had 3 total glands open on the right eye and 7 on the left eye. So that was obviously not enough. She's not drinking enough. She's using cosmetics too much, and she's not taking them off when she goes to bed. She does not have corneal neuropathic pain. And then what we did with the goggle test is we put her in a microenvironment with 100% humidity by putting her in a swim goggle that has some saline solution in there. And we asked the patient to say, how much discomfort do you have? And we do that at 5-minute intervals. And she went from a grade D with her contact lenses to a grade B in a span of about 20 minutes. Okay, go ahead. And then her sedentary lifestyle, obviously. So what did we do? So for the lid wiper, I put her on Lotamax ointment at bedtime for 2 weeks. That will also help her with her nocturnal lagophthalmos. I put her on Regenerize Professional Strength. She was on that twice a day for 3 months. And then we put her down to the light version for another 6 months. I did a lip. Now, we had to do 3. And here I want to make a point, because when you look in the literature, all of these devices that do expression help. There hasn't been a great trial head-to-head of any of them, but all of them do something. The point I want to make, though, is that it can be very difficult for one session to completely rehabilitate a gland. And so when what comes out of the gland on your follow-up exam looks like olive oil, then you're in maintenance mode. But until that happens, you still are trying to rehabilitate the gland. And so I shared that with the patient right up front. I said, you have significant disease. I'm hoping that one treatment's going to be enough, but it might not be. And so she was on board with that, and she knew what to expect. And that avoids a lot of patients saying, oh, the IPL didn't do anything for me, or, I did a session and it didn't work. I mean, some people just need more. I decided to defer fitting the lenses because I thought they were good. At-home therapies included new lids, which she got because of her makeup use. I wanted her to do warm compresses. But in our clinic, for patients who have filtering blebs, transplants, keratoconus, something where you don't want something actually pressing on the eye, we use the iCloud, but instead of having 2 inserts, we use 1, and we feel like that's a bit safer. She did not do it until she had to pay for that second LipiFlow, and then she started doing it. So that was the only thing that motivated her. She had to blink when she was on screen. She had to drink more free water. After she finished the Lotamax, I put her on Cica Forte every night for lid seal. I got her a primary care doctor. They supplemented her with 5,000 IU for a month, and then she went to 1,000 a month, and she's following up with the PCP on that. I told her she could still use the Retain MGD, but no more than 4 times a day, and I added Tangible Boost. So the lifestyle changes were pretty significant for her. I said, you're going cold turkey on makeup around the eyes for 2 months. And then I gave her information about Credo Beauty and Eyes Are the Story, so that when she gets new makeup again, her habits will be better, maybe stuff that's not so toxic to her eyelid tissue. And then I said, you got to reduce your screen time because that's a major contributor to your problem. So we talked about that. And then both myself and her PCP recommended that she try to do even walking, but some kind of exercise. It took a while. She was a little bit discouraged at first, but I had set it up that it was a marathon and not a sprint. By 6 months, she could wear her contact lenses for about 10 hours. She was ready to take them out at 10 hours, but it definitely was better than before. Her lid wiper was gone. Her morning symptoms were gone. And we did not refit her lenses, but I endorsed annual replacement and trying to keep them really clean. And I also told her that because of her screen use, she's probably going to need some kind of LipiFlow or some in-office treatment 1 to 2 times a year just to maintain what she had. And I like this story because there's a few things. One is that it's a keratoconus patient with dry eye. 2 is that in young people, significant meibomian gland disease can be non-obvious. And so sometimes you need to have a meibographer. If you don't have one, just call up someone who does and ask them if you can send patients over there once in a while just for the test. Thirdly, she didn't just have MGD. So if I just did a LipiFlow on this patient, it would have failed. This patient had nocturnal lagophthalmos, which is common in patients with keratoconus because they have floppy eyelids. She was vitamin D deficient. She was dehydrated. She had too much time on the computer. She had too much of the makeup. So it was all of these things that we had to tackle in concert in order to get the kind of outcome that we wanted. So I'm going to send this over to Jeff now. He's going to tell you a few things about some of his patients.
All right. Well, look, every time I hear Dr. Now speak, it reminds me that I'm in the presence of greatness. I mean, you guys see, she functions so much higher than most of us when it comes to treating dry eyes and evaluating dry eyes. And so I love to learn from her every time we get together like this. My story is a little bit different. Here are my disclosure slides, but really what I want to do is tell you just a little bit about kind of how I got to be in practice and where my path took me. So I started out my career in an academic medical center. So I came right from cornea and contact lens residency, academic medical center, where I was seeing complex contact lens patients from day one in practice. And when I was at this academic medical center, I built up the region's largest specialty contact lens practice. And, I just got to the point where I realized I kind of wanted to be in charge of my own ship. And so I left academic medical practice to join my wife in practice, who's an optometrist. She had started just a small private practice about 2 blocks away from this academic medical center. And immediately when she got into practice, she became busy. And so she grew the practice, grew it, and I got to the point where I was looking at her lifestyle and I was looking at my lifestyle, and I was seeing 25 patients in a half day with 1 tech. And I'm like, gosh, I just don't want to live like that anymore. I don't want my patients to have to go through those kinds of wait times anymore. So I left there. And what I thought is I would just join my wife in just a normal Main Street, glasses and contact lens practice. And that is not at all what happened, because, about 80% of my complex contact patients immediately followed me over to private practice. And then in the ensuing probably 3 years, the rest of the 20% came. So immediately I was busy with complex contact lens patients. And then what happened was I let all of the community ophthalmologists know that I was now doing this in private practice. And so instead of being fed by 2 cornea specialists at the academic medical center, I was now fed by about 12 ophthalmologists from outside of this medical center. And then slowly but surely, some optometrists actually started sending to me. And so at the point where I am now in my career, I actually don't see any general eye exams. All I do is complex contact lens. Every single patient I see has some kind of complex contact lens need. And what is the number 1 diagnosis of any complex contact lens practice? Keratoconus, right? And so we've built up just a really, really strong keratoconus practice. I threw this slide in there that, we practice with the highest technology available. Every single one of my visits, if they have a scleral lens, we're doing OCT evaluation on them. We're using wavefront aberrometry to really figure out if there's significant coma or things on the posterior cornea that are going to get in our way. And really, the way that I've built my practice is on technology. We just use the top technology in the field to make sure that we get the best possible outcomes for patients. I just wanted to show you an image because I love this image. It is a lens that has basically absolutely no wetting on the front surface of a scleral lens, right? So you can see all of the tears beating up on the front surface, almost like as if there were like Rain-X or some kind of hydrophobic surface to that front surface. And this is basically the worst possible case you can have of a non-wetting scleral lens, okay? But I will tell you that in my practice, the number 1 problem we have, the number 1 complication we run into by far is when we perfectly fit a scleral lens, but the patient has underlying MGD so that they have drying on the front surface of that lens. It's the number 1 thing we run into by far. And so what we did is, because I'm busy enough doing what I do, I don't have time to start a dry eye practice within my practice. But what we did is we brought in an associate into our practice who had a very big interest in treating dry eyes. And we now share these patients. So when I see a patient with MGD, we don't wait until we fail with scleral lenses. I immediately send this patient to start working with my associate, Dr. Hayden Motz, and I work on getting the contact lenses well fit, so that we are both working on the patient together to make sure we have the best outcome. And I will tell you that patients absolutely love this idea, because they know that they have dry eyes. If they have keratoconus, they know they have allergies, and they know that those allergies have led to dryness, right? And so they love the idea of, fixing a problem before it actually comes. And they love the fact that we kind of predict if they're going to run into this problem. And so with patients like this, where there's absolutely no drying, what do we do about this? Or no wetting, sorry. In that last video, that's not the norm of what we see, right? This is the norm of what we see, right? And if you look very closely, and this should be, we'll play this video over and over, you can actually watch as the front surface of this lens, the tears evaporate away. You can see it right in here, okay? Right in where the light reflex is from the biomicroscope. And watch it again. So the patient blinks and you see it. You see the film grow. That film is basically just non-wetting of the front surface of this lens. And so we know this patient is going to be uncomfortable, and we know that the vision is going to suffer in this patient. So what do we do about this? This is the same exact patient with, and let me play this video so you can see them both going at the same time. Same exact patient, and this is with HydroPeg treatment. So the very first line in what we do from the contact lens perspective is we have these lenses coated with HydroPeg. Now, I've found that, most of the patients have some level of MGD when they're, long-term contact lens wearers. And so we don't wait to put on HydroPeg coating anymore. All of our lenses come with HydroPeg coating. We don't want to waste the visits trying to figure this out. So we just put it on all our lenses to start. So back to this first patient, right? Same exact patient, exact lens, but with HydroPeg coating. You see the difference? I mean, you can actually see the tears floating freely on the front surface of this lens. So HydroPeg is a very big part of what we do, but it's not the only part, because even with HydroPeg coating, you will still run into problems with dry eyes. So here's my case, and this I just love this case because she embodies the things that we talk about here. So she's 40 years old, female, HR director. Her complaints are decreased vision with her scleral lens in her left eye. Okay. She was sent by her dry eye specialist 4 years ago for scleral lenses. She has Sjogren's syndrome. And upon further questioning, she does not put a rub step in at the end of her lens wear. And she basically has no compliance with the dry eye regimen that her referring OD put her on. So here are her lenses. And this is an OCT image. So here we have the front surface of the lens, we have the back surface of the lens, and we have the cornea. And then we stick a caliper on here to figure out how much volume is above the cornea. And what we're aiming for is about 200 microns. So we hit 236. And you can see the surface is relatively parallel of the back surface of the lens and the front surface of the cornea. Here are all of the meridians of the edges and the haptics of these lenses. And you can see that we vault the limbal stem cells right here. So this is a very important factor that we're not pressing on limbal stem cells in my practice. And so we just want to make sure that we don't touch that limbus. And you can see here, the cornea ends right about here, right where you see that little spur. And so, we have a nice even apposition of the haptic of this lens to the sclera in 360 degrees. You can see it here, and you can see it here. And incidentally, in the en face image, you can actually see how this lens is rotating on the eye. So then let's look at the video of this patient, because this is her wearing her scleral lens. And this is the left eye, the one she's complaining about. And so what do we notice about this? Amy, is your audio still on? You want to comment on this video at all? What do we notice here?
Yeah, I mean, you can see on her lid margin, she's wearing dense eyeliner.
I knew you would pick that up. That is the non-obvious thing that I was hoping to pull out. And I knew immediately you would pick that up. I'll play it again.
It's because we see it so much, so common.
Right.
I mean, that's horrendous.
What do you notice about the central part of the sclera? I'm sorry, not the sclera, the cornea, the front surface of the lens.
Well, it's got makeup on it. That might be underneath. I can't tell, but there's definitely soiling on the front.
Yeah, so these are areas of non-wetting right on the front surface of this lens. It's just basically dry spots right on the front. And you can actually see some of the makeup sitting right on those dry spots. Now you can see here, she has some kind of debris or some kind of fiber trapped underneath. I mean, there's just a whole bunch of stuff going on in this video.
Jeff, don't you find that you tell people about this and they ignore you, and then they've just gotten a new scleral and then they get so mad because they have to buy another one?
You know, I'll tell you something. Yes, I know exactly what you're talking about, but I feel like in this case, this scleral lens is salvageable, right? We have that little non-wetting area that I think if she just drills solution into that, she could get that to wet. And then obviously we had to change some of her habits, like with the makeup. So here's the plan with her. We discussed a rub and rinse, right? So when she takes her lenses off at the end of the day, rubbing in with unique pH or some kind of very viscous solution on a multi-purpose GP solution, but a peroxide-based cleaner every night, okay? And then obviously we talked to her about reducing the cosmetics use. You know, I think in her case, that is one of the major issues. I mean, you could see back in that video, she basically just plugged her entire meibomian gland structure with who knows what was in that. It was probably tar, right? I'm sure it was petroleum based. I'm sure it was a you know, one that was not a non-wetting makeup. And so if she just reduces that cosmetic use, I feel like this is recoverable. But then we also returned her to her referring OD for dry eye regimen refresh, because she's not going to do this just by avoiding makeup on her own. Amy, do you want to take back over and talk a little bit about some of the science?
Yeah, we just have a couple of minutes left. And so I just wanted to review some highlights of a study that I did with Jennifer Harthan. And we've submitted this and presented it at ARVO a couple times, and now, you know, the paper's submitted. But I just want to give you the very Cliff Notes version about this. So, you know, because people who see a lot of cones, see that there's MGD, know that there's not a lot in the literature about Casey and MGD specifically, we decided to do a test. So this was a prospective 2 sites, so Boston, Chicago, just a single visit cross-sectional study. So it included, you know, the full medical ocular lens history. What we did for the study was MGE, meibography, speed, and then we had a whole bunch of activities of daily living questions and contact lens tolerance. And we had 28 males and 29 females, and they had a pretty decent age range, but the median age was kind of middle age. So these patients have been in lenses for a while. Go ahead, Jeff. And so the results, the average number of functional glands using the MGE was six, basically between 6 and 7 glands per eyelid. About 43% of the glands were dilated on meibography. And this was impressive to me. 94% of the keratoconus patients had some gland atrophy. If you look at confocal microscopic studies of meibomian glands, that's the end game, right? There's nothing that you come back for with atrophy. So that was a lot, you know. They were symptomatic. So the speed score ranged from nothing in some patients to 20, but it was about 9.5. If it's over 6, it probably means that they're symptomatic. Not surprisingly, especially given the makeup situations that we've talked about today, females were more symptomatic than males. And what we found in the end, that the symptoms of dryness were correlated to the amount of gland atrophy and the meibomian glands that were functional using the MGE. So in conclusion, the symptoms that they were having were correlated to atrophy and gland function, as I just mentioned. But contact lens discomfort was correlated to atrophy and gland dilation. And so I think, it's really important to realize that keratoconus patients are just like everybody else, but they have the added risk factor of full-time contact lens wear, and they have to wear these lenses forever right now. So I've got this 35-year-old now with horrendous MGD, and she's going to be only 65 in 30 years, so what's going to happen to her? Can she wear contact lenses through that entire span of time? And so I just want to kind of make everyone think a second. If they have a patient with keratoconus and they're not comfortable with their lenses, just grabbing a scleral isn't necessarily going to solve all your problems. It can make them more comfortable. I love scleral lenses. I fit them a ton, but some have to look a little bit beyond that and investigate a little bit further. Jeff, do you have any comments about, your experience with Hayden and how your patients have benefited? Is it helping them? Are you being a little more aggressive with the KC patients than a non-KC person?
We definitely see improvements when the patients go all in, right? And I love how you mentioned earlier on with LipiFlow that you mentioned to the patients, one treatment will not be the answer here, right? It's going to take serial treatments before they start to see results. And we use the same, paradigm in our practice where we tell those patients, look, we actually don't use LipiFlow. We use a different type of gland clearance system. But we tell them, we say, it's going to take, 3 to 6 months of doing this serially before we start to see an effect. And it's funny, I know for a fact that other doctors are not telling their dry eye patients this because I'm on a consumer-driven Facebook group about scleral lenses. And you see these posts come up all the time. Hey, my doctor recommended LipiFlow or, tear care or something like that. And, what's been everyone's experience? And you start to see the comments come. It didn't work for me. It didn't work for me. I had it done once. It didn't work for me. It didn't work. It didn't work. It didn't work. Right. And
you had it done once, but you're still sleeping with your eyes open all night and then using a computer for 14 hours a day. Right. Like it's that whole package. Like you have to make them realize that some of this they have to take ownership of.
Right.
So, all right. So I guess if there's any questions, we can maybe kind of go to that.
Dr. Now, do you have the patient use Retain MGD with the contact lens?
So it depends on the patient. I definitely have patients use Retain MGD with their contact lens. I don't think that there's a magic drop that works for everybody. I don't know about you, Jeff. I tend to try to do non-preserved. If someone has MGD, then they're lipid deficient. So I'm going to try to supplement with the lipid to try to decrease evaporation on the surface of the lens. And I think you did this so well, Jeff, as you said, look, you got to pay attention to the ocular surface. But what about the real estate on the surface of the lens? That poor eyelid's going over that, 10,000 times a day. And that can get dry too, So if it's a lipid deficiency, I'll usually do a lipid-based drop. And there's several out there. I don't have a favorite. Punctal plugs too. I don't know, you probably use some plugs in your practice too, to try to get some more wetting on the front surface of the lens.
We've shied away from plugs in recent years. Really, if it's a crappy, swampy tear film, then plugging that up further, I feel like is just, exacerbating the problem. Really what we do when we see, these level of swampy tears is we really go to town on the basic level of why they are bad quality in the first place. A question for you, this is my own question. So we've just recently started using the biologics to try to supplement after we do like an amniotic membrane. How have you found that? And how do you incorporate that? Do you use the biologic as your first line? Do you use it after you've already, treated the patient with an amniotic membrane? Tell us a little bit about that.
So we are very interested in corneal nerve pain in our practice. We feel like a lot of patients are probably running around with low grade to mid grade corneal hyperalgesia. And although I do send some patients over to Tufts to get confocal microscopy images, what I have found is that you can often tell that they have this problem by their symptoms, right? So what is abnormal? It is abnormal for your eyes to burn. It is abnormal for them to tear excessively in the wind. It is abnormal to be in pain when someone puts the air conditioner on in the car, right? What causes that? The corneal nerves cause that. So if I do a proparacaine test and there's an index of suspicion for some neuropathic pain, or I do a goggle test and they don't get better, and they have all of these symptoms, and I've done everything I'm supposed to do on the tear film side, and they aren't feeling better, they probably have corneal nerve abnormalities. And so it's then that I say, you got to do the biologics. And they take a while to work, but we've had really, really good success with serum and amniotic fluid drops. So
question that came in.
Go, no go.
Sorry. Question that came in. Can the name of the multi-center study be repeated, please?
Oh, so we submitted it right now. I don't know if their reviewers are going to object to what we call it or whatever. So I think right now it's keratoconus in MGD in a keratoconus cohort or something like that. We have, it's in ARVO a couple times. If you just put keratoconus, meibomian gland dysfunction, there are 2 separate posters on that. And then the paper is being reviewed right now.
Great. Okay, next question. Is it okay to instill a drop of sequa in the scleral reservoir if the patient already been on it successfully? Are there any concerns for this practice, or is it more preferred to use autologous?
So I don't know about you, Jeff, but sequa is a chemical. And I don't think I want that in the belly of the lens the whole day. What's your thought on that?
I agree. We try to put as little as we possibly can in the bowl of that scleral. And really what we're doing is just jockeying between the approved or non-approved, for that matter, solutions that are non-preserved.
Yeah, I do put serum in the lens sometimes, but usually it's sticky. Have you found that serum's like pretty sticky?
Yes. So we will dilute it very significantly. I'm talking 1 drop, 2 drops, and it really depends on what concentration of autologous you order for that patient.
Yeah, I don't have too many keratoconus patients on serum.
I don't either. It's mostly the dry eye patients.
Yeah.
Next question. What amniotic membrane do you prefer? I'll field that one first if it's okay. So there has never, ever been a study that's shown that there's any difference between a dry amniotic membrane and a cryopreserved membrane. And so we are doing almost all dry amniotic membranes. And really it just comes down to cost, because a lot of, these guys are all using the same procedures, right? So there's really no difference that we find between the different amniotic membrane. And then it's just a business question of, which one is going to provide it to us at the best cost. How do you? I
agree. We use the dried ones, but I'll say in the context of cones, it's a little hard to get them to stay on, right? I mean, we have some of the 8.2 ProClear base curve lenses to try to keep them on, but it's not like you can just kind of slap on an Oasis on a cone patient and get them to stick. So I don't have great luck. I maybe have only done it twice on a cone, and both times things kind of slid around and I was not satisfied with it. So other like Moshe Schwartz, he might have a much better experience, or I don't know, but in my hands, it hasn't been something I go to very much. But I can see, if you've got that vortex epitheliopathy, that would be cool if it made that go away. That'd be a great case series if anyone had a chance to do that.
Yeah, this is one of the only times that I'm a proponent of silicone hydrogel lenses, right? So a stiff, soft lens that is going to be horrifically uncomfortable on the patient, but is going to stick around because it's stiff and it stays, is usually what I'm doing with keratocones. Next question, and this is for you, Dr. Now. What is the goggles test?
Oh, so it is a way that you can create a 100% humidity environment right around the eyes. So you just take a pair of swim goggles and you put in maybe a teaspoon of saline in each eye. You just put that on, and the patient grades their comfort at 5-minute intervals. So you'll get their comfort line. We do it like a grade F, which is like you're failing, to A, which is just like in school, is awesome. And so we do three grades at baseline, and then you put the goggles on, and we just see what happens over the course of 20 to 40 minutes. So if a patient increases by 2 grades, we know that they have a really good prognosis for feeling better if you can optimize what's going on the surface of their eye. So it's kind of a test for corneal hyperalgesia, corneal neuropathic pain. But in the context of our patient we talked about today, that patient has a contact lens on. And can I improve their contact lens without refitting them just by optimizing their tear film?
We find that too. And we find success in doing that because, we know that we're fitting them in my practice at the best possible fit they can have. And then there's just factors beyond that make it, uncomfortable. How are we doing on time? I don't know when this session ends. Oh, okay. I just got a 2-minute warning. So why don't we hit 2 more questions? So similar to the last question, what's the goggles test? This question is, what is your Preparicane challenge test?
Mm-hmm. So Preparicane is a way that you can test the afferent nerves for the cornea. So if you have corneal nerves that are very mad because they've been sitting in a toxic milieu for 10 years, they're going to be hypersensitive. Okay. And so if you instill Preparicane, the pain should go away. I mean, you have to say, hey, you have to disentangle the fact that your eyelids feel kind of numb, but does that burning pain stop? And if it stops when you administer Preparicane, then you know that they don't have corneal neuropathic pain. They still might have nerves that are hypersensitive, but it's not going to be centralized. And so they have a much better prognosis for improvement than someone who does not improve after stopping the afferent input.
Okay, last question. Do you ask your scleral patients to do warm compresses with sclerals in or out? Any difference?
I always say out. I don't know. What do you do?
Always do out. I don't want all of that bacterial debris spilling onto the surface and then potentially infect scleral lens. Yeah. I mean, look, when we're teaching our scleral lens patients what to do, at the first dispense, we tell them flat out, look, when you listen to every single thing we do and every solution that we want touching these lenses, we don't have complications. We simply don't see the complications. The complications come when patients get in their something they've read online that is not approved by us. And then they're putting some kind of thing on that surface or in that bowl, and they get infections and they get the complications. So, we tell them specifically, we tell them, do your hot compresses when your scleral lenses are out.
Yeah. And that's why I like that eye cloud too, because it gives you a little space between there. So it's just less pushing on an eye that's going to be more prone to deformation. And, God forbid you do that with a bleb, right? I mean, that's not the best. I think people don't always think about that stuff.
Right. Well, guys, thank you so much. This has been a lot of fun to give this talk. And I think we are at the end of our time.
Okay, thank you. It's great to be here. Nice to work with you, Jeff.
All right. Bye-bye.